All right, and so the last chapter we have as far as lectures online go for this week is going to be chapter 16, and it's the Introduction to Dental Imaging Examinations. So we're going to talk about the different type of radiographs we can take and why we would choose each of those. Learning objectives for this chapter will be to define the key terms associated with dental imaging examinations. We're going to list the three types of intraoral imaging examinations. We'll describe the purpose, the type of receptor, and the technique used for each of the three types of intraoral imaging examinations. Say that 10 times fast. And then we're going to list the various projections that constitute a complete mouth series. We will list the general diagnostic criteria for intraoral images. We'll list examples of extraoral imaging examinations. We'll discuss the prescribing of dental images, and we'll describe when prescribing a complete mouth series for a new patient is warranted. We need to understand when we would take a full mouth series. All right, and what is the purpose of this chapter? We need to introduce the radiographer to the different intraoral radiographic examinations used in dentistry. For those of you who are completely new to dentistry, you haven't seen all of the different types of radiographs that we can take, and so we need to introduce you to them. We need to define that complete mouth series, which is also called a full mouth series or an FMX, and we need to describe in detail the diagnostic criteria of intraoral images. I know we've gone over what, density and contrast and things like that are, but here we're going to be talking about what a good X-ray needs to look like. As far as intraoral imaging examinations go, there are, we're going to talk about the types of intraoral imaging examinations. There's three different types. We're going to talk what makes up a complete mouth series, and then we're going to talk about that diagnostic criteria, the density, contrast, and such. Intraoral examinations are the foundation of dental imaging. These guys are what people think of when we think about taking dental x-rays. We're talking about this. Okay, so for intraoral imaging, we are doing an inspection of the teeth and the intraoral adjacent structure. So we're looking at the bone, we're looking at the roots of the teeth, we're looking at maybe the sinus, we're looking at, any of those nutrient canals. We're looking at all of those kinds of things when we look at intraoral imaging examinations. It does require the use of an intraoral image receptor, either film or digital. And what makes it intraoral receptor over extraoral is that we place it inside the mouth in order to capture those teeth and supporting structure images. Intraoral film and intraoral digital sensors are the most commonly used X-ray film and X-ray sensors. And so typically, you take more dental images in your lifetime than you will of other medical sort of radiographs. And like I said, there's three different types of intraoral images. And so we have periapical examinations, we have interproximal examination, and we have an occlusal examination. So we're going to get into each of these. Each of these examinations has a certain purpose. There's a reason why we take it, and it requires the use of both a specific type of imaging receptor and it requires a specific technique in order to capture them properly. And so first up is the periapical examination. For this one, we are looking at the entire tooth and the bone that supports that tooth. Here, we're going to be using, it says periapical receptor. On an adult, we would use a size 2 receptor of some kind, either film or digital sensor, in order to take an adult periapical X-ray. The technique that we use is either paralleling or bisecting. We'll talk about those more in class, not this week, but probably the following week. And this one, it's a periapical, actually means peri, which is around, and apical, which refers to the end of the root, the tip of the root. And so for this radiograph, the main area that you must capture is this area right here around the tips of these roots. You need to have 2 to 3 millimeters worth of bone above where the tip of this root ends in order for this to be a diagnostic radiograph. You do have to have the crown of the tooth, the occlusal or the incisal surface of these teeth as well. And so this is not a proper radiograph unless the entire tooth is showing and 2 to 3 millimeters of bone around the tips of these roots. The reason for that is that if a patient were to get a cavity on the side of the tooth here, it would burrow in towards the nerve of this tooth, and then that abscess or that infection would travel up the tip of this root and it would come out here. And then we would have an area here on this x-ray. If we had an infection, we would see a radiolucency or a darkness around the tip of this root. And that would mean that the cavity had traveled all the way through this enamel and dentin and had traveled into the nerve of the tooth and then traveled up. Infection always takes the route of least resistance, and so it's much easier for this infection to grow when it comes into this nerve canal and then just travels up the canal versus trying to like burrow its way back out through the side of the tooth. And so infections always take the path of least resistance, just like water. And so the infection will burrow in to get to the nerve, and then it will travel up the nerve, and it will, because this bone up here is actually much softer and it's more porous than the tooth structure. So when it travels up here, it's able to eat away at the bone that's up here. And so you must have all of these factors when we look at periapical teeth radiographs. All right, and so then next is the interproximal examination. And when we say interproximal, we mean bite wings. We're taking bite wing x-rays here. And so the main area that we must capture on this radiograph is both the crowns of the maxillary arch and the mandibular arch. We want both of these teeth completely in the film. The other area that we need to capture is this crestal bone, this area right here, where when we look at this little black triangle here in between the teeth, we can see where the bone level sits in relation to where the enamel ends. And so this area right here, if when we take this radiograph, I can't see the bone level, it means either one, I didn't get a very good shot of this area, or two, I would need to take a different type of radiograph in order to capture the bone level, because the bone level is very important when we look at whether this patient has periodontal disease or not. We have to use bite wings when we are measuring for periodontal disease because of the angle that we use to take these radiographs. And I'm going to say this to you a million times later, so don't really worry about it too much. The other thing that we need to get on a bite wing radiograph is called an open contact. And now, if any of you guys were assistants beforehand, you already know opening contacts on bite wings can be sometimes a challenge. Some people have a little bit harder of a time kind of getting the concept of it, but we are definitely going to send this home. The thing we're looking for is this little area right here in between the teeth. You can see where these two teeth touch one another. There's this little black line right in the middle. And that means that the x-rays were able to travel between the teeth, and we're able to see both this entire tooth on the left, and we're able to see the entire tooth that's on the right. And that is important because if the patient were to get a cavity in between these teeth, that is the area where it would show up. So the beginning of a cavity is very small, and it happens just underneath where the two teeth touch one another. And so in order to be able to tell if the patient has cavities, we have to open the contacts. We have to be able to see in between the teeth, right? What you'll see when it looks, none of these are really overlapped. This one's pretty close, but it's not. It's mostly just, the whiteness of this silver filling right here. If the area in between these two teeth has kind of like this little lighter sort of space in between the two, then that means that the contacts are overlapped. And that would be grounds for having to take a retake of this image. And so it's very important, one, that we're able to capture both the upper and lower teeth on the same film, but also that we are opening the contacts too. And when you guys are in the class for bite wings for that lab, that's when we're going to talk about that. So I think if this is week 4's lectures, then we would have talked about bite wings last week. So you already know what I'm talking about. Okay, and so then this one is called an occlusal examination. It's called an occlusal examination because of the technique. The occlusal technique makes the patient bite onto or occlude onto the receptor itself. It's the only one like that, where instead of just biting on the outside of the film, like the film is inside the teeth, this is the one where the patient bites directly on the film. It's used to examine large areas of the maxilla and the mandible on one, or, sorry, not both, just the maxilla or the mandible on one film. You can see in this image here, this is just the mandible. And we do this mostly on children. It's not usually done too often in general practices or in like perio offices or things like that. Mostly this is done in pedo offices, and it's done so to make sure that the adult teeth are present. And so if we were to take this radiograph and we saw a baby tooth, but we didn't see an area underneath indicating that the permanent tooth was still like waiting to erupt, then we would know that the patient was missing, congenitally missing that tooth. And so you guys will talk about congenitally missing teeth in your dental anatomy and head and neck anatomy and things like that. But for the purpose for this, that's what we're looking for. We're looking to make sure that all of the teeth are present. We wouldn't be able to tell bone loss or cavities or anything like that from this one. We use typically an occlusal receptor for film. It's going to be a size 4 for adults, although I don't know if you would really do it on an adult. And then for a kiddo, sometimes we'll just use a size 2, depending on how big they are. Then we could just use the size 2 in order to take an occlusal radiograph. Let's see. Yeah, it's usually used in pedo, and I think we've covered everything on this one. Okay, so then this one is our complete mouth series or a full mouth series. I've never seen a CMS used like in private practice or anything like that. You might, maybe if you work in kind of one of those weirder offices, but most of the time you're going to see this one right here, FMX, and that means full mouth series, or X just stands for X-rays. The full mouth series will capture all of the areas that either should have teeth, the edentulous areas where maybe patients are missing teeth, and the areas where the teeth are. And so areas where teeth should be and areas where the teeth are all areas called tooth bearing, and those are all of the areas we should be capturing in this series. The series can include both periapicals, these. It includes bite wings. It includes posterior periapicals, and it also includes anterior periapicals as well. There's usually anywhere between 14 to 20 films, depending on the patient, depending on the sensor size you use, depending on the individual issue, like your dentist, whatever they recommend. And so most of the time, you'll always take these 4 bite wings on an adult. And then most of the time, you'll take both of the mandibular. I've had instances where I'm able to capture both the premolars and the molars in one shot on the maxillary periapical posterior ones, but that just depends on the person, depends on how big their teeth are and how much space they have in there. A lot of the play between those really comes into the anterior. So sometimes they'll take 4 across the top, and then it would be this one's for the canine, this is for the lateral and central, this one is for the lateral and central, and this one is for the canine. Sometimes that's how that works. Sometimes you'll only take 3, in which case this center film would be for the 2 centrals, and then the 2 lateral films would be for both a lateral and a canine, and you'll get both of those teeth in the same shot. But some people they either have too big of teeth or they have too much space in between their teeth, and so you can't capture all of those teeth in one film and have a diagnostic film as well. I've seen some instances where I'm able to capture, if they kind of have a smaller mouth and the teeth are super close together, I'm able to get both or all 6 of those lower anteriors in 2 films. And so I'll have, central to canine, and sometimes I can't. And so then I'll be taking 3, and I'll take the 2 centrals, I'll take the lateral and the canine, and I'll take the lateral and the canine. I haven't seen too many instances where you have to do, the canine, lateral and central canine kind of thing on the bottom, just because of how small and close together the lower anterior typically are. But if you work in an office that wants that, then go for it. Film size selection is pretty important here. Typically on an adult, for all of the posterior ones, you are using size 2. Most of the time with digital sensors, you only have the one sensor. You just use, the one size two for everything. But sometimes patients don't have a large enough mouth. And so, in the anterior, you might consider using a size one on the patient. And that's really just depends on if your office has that available for you in a digital sensor, then you could use it. If they don't, then you just do the best that you can. It's uncomfortable for a patient, and that's important to know. It's important to have had one of these series taken on you before, because I want you to know what that feels like. And so it's not comfortable. It's not painful, but it's certainly not comfortable, and you need to be aware of that when you're doing this to your patients. Most of the time, they will take a full mouth series every 3 to 5 years. Wow, writing with a mouse is super hard. But anyway, 3 to 5 years is how often we typically take radiographs of a full mouth series. It just depends on your patient, how cavity prone they are. Most of the time, insurance companies, even though they're not supposed to dictate treatment, they will say, okay, we'll pay for a full mouth series every 3 to 5 years. And whatever the insurance company says, that's kind of what the office does. It's not right, but it does happen. And so you need to be aware of that. If your patient is very prone to getting cavities, and their insurance only covers x-ray, the full mouth series x-rays every 5 years, then you might want to let that patient know, hey, we need to take these a little bit more often. And so you're either going to be paying out of pocket for that, or maybe you should consider getting a better insurance. And so just be really upfront with your patient about why you would recommend something like this, what the dentist is thinking when they're recommending these x-rays, and letting them know. Okay, so I know we've talked about how, kVp, milliamperage, exposure time, and subject thickness will affect our density, our contrast, our definition, and our detail, although definition and detail, those are both the same thing. Not really sure what the book thought when they were making these different words. But anyway, so the density really needs to be both not too dark and not too light. We want to have a nice balance between areas that are dark and areas that are light. In contrast, we want a balance between areas that are black and white and those shades of gray. We don't want too many shades of gray, but we don't want too many shades of black and white either, right? We want that balance. And then when it comes to detail, we want as much detail as we can possibly get. We want our images to be as sharp as they possibly can. And as far as distortion goes, we want the least amount of distortion we can possibly get on our patients. If we have too much distortion, then we need to retake that radiograph, and we'll talk a little bit about that as far as what those teeth look like when we talk in chapter 20. We're going to go over that one in class about what a radiograph would look like if we use the wrong angle. But anyway, the complete mouth series needs to include images that show all of those tooth-bearing areas. So if you feel really sorry for your patient and you don't want to put that receptor in there far enough so that we can see that patient's wisdom tooth, then you're doing your patient a disservice, because we need to know what the backside of that wisdom tooth looks like. Okay, we need to know if they have a cavity on it, and so you need to get that receptor in there. Periapical images have to show the entire crowns and the roots of the teeth being examined, as well as 2 to 3 millimeters beyond the root apices, which is what we talked about. And then bite wing images must show open contacts. That's not something we've discussed yet. We're going to discuss that one when we go over bite wing radiographs in class together. I'm recording this one a week ahead, so that's why. But I'll show you how to open contacts. Okay, and extraoral imaging, these are my favorite. These areas show a large area of the skull or the jaws. They typically will capture areas we are not able to capture in intraoral films. The key here is that the receptor is placed on the outside of the mouth and not inside the mouth, right? And most of the time what happens is, you're not able to capture maybe a wisdom tooth that is impacted. It's not grown in yet. And so, if you can't catch it with an intraoral receptor, then we might want to take a panoramic or some other type of extraoral imaging examination in order to capture that image so we know what's going on with that tooth that's in there. Most of the radiographs that you'll see as far as extraoral, they include the panoramic and the cephalometric. Those are the most common ones. You can find this on figure 16-5 in your book. Okay, so then here's that image, that panoramic image right there. You can see that this image allows us to look at the jaw. It allows us to look at the sinuses. We can even see a little bit of the orbital cavities in this radiograph. We can see the a little bit at least of the spinal column along the side. This area right here, this is a hyoid bone, and we're able to see all of these teeth. You can see that this patient recently had some extractions because you can see these areas in this bone where it looks like those roots used to be, right? And so this is a really nice way to look at a lot of structures all in one image. Also, you can tell that the tube head the tube head that goes around the back of the patient's head on the extraoral examination actually hit that patient's shoulder, the back of their shoulder, the back of their neck when it was going around, because that's how you get that little white mark on there. But anyway, that is an error right there. The most common are going to be the panoramic and the cephalometric. Cephalometric x-rays are used in orthodontics to see where the position of the jaw is in relation to where the upper jaw. Well, I always say the jaw is the lower jaw. The up is a part of your skull. The maxillary is always just a part of your skull. So when I say jaw, I usually typically mean the mandible. But the cephalometric tells you where the mandible is in relation to the maxillary. And the rest of these, the lateral jaw, the posterior, anterior, and the waters, these are not very common, and you really don't need to worry about those. Prescribing dental images. So in case you hadn't noticed, this is a pretty important topic. That's why we talk about this in almost every single chapter. Prescription of radiographs needs to happen from the dentist, and it needs to be based on the individual needs of the patient. Okay, I cannot stress to you enough how much we have to really take into account the individual person when we are prescribing radiographs. If you have a patient who, they eat uh, 3 bags of Skittles every single day, then you need to take radiographs on that person a little bit more, okay? And you need to let the dentist know, hey, the patient said that they don't use fluoride and they eat 3 bags of Skittles every day and they go through, a case of Coke every 2 days. Like, you need to let your patient know or your dentist know so that they can say, okay, you need to take radiographs on that patient every 6 months. We need to make sure that that patient's not going to get cavities. And at the same time, you need to let your patient or your dentist know, this patient is exemplary. They've never had a cavity in their life. You need to have that conversation with your dentist where you say, here are the individual criteria that this patient presents with, and we need to use these factors. We need to put these factors into our decision. The dentist uses their professional judgment to make those decisions about the number, the type, and the frequency of those dental images. On that same note, not all patients need a complete mouth series every time they come into our office. So a complete mouth series, or FMX, is appropriate when a new patient, a new adult patient, presents with clinical evidence of a generalized dental disease or a history of extensive dental treatment. And so we need to take these into account. If our patient comes in and they are 20 years old and they've never had a cavity in their life and they did have their wisdom teeth removed, then maybe we're not taking a complete mouth series on them. We're just going to take, 4 bite wings and 3 PAs and maybe a pano, maybe, right? It really depends on the patient. Otherwise, a combination of bite wings, selected periapicals, and or a panoramic image should be prescribed on the basis of a patient's individual needs. This happened to me a lot in private practice where my patient would come in, they wouldn't have a very extensive history of dental disease, and they would be new to me. And so I would go to my dentist and I would say, they don't have any problems. I took a peek around in there. They don't have any, they don't have a lot of fillings. They don't have any issues. They're young, they're healthy. I would ask them questions about their diet, and I would let him know, hey, I think that we could just do this in, 4 bite wings, 3 PAs, and a pano. What do you think? And then he would say yes or no, and we would go from there. And it's really important to have that conversation with your dentist, just like I was saying before. Okay, so if you have questions, please post them or send me an email or let me know, and I will see you in lab.